bring you our next speaker. I find it actually quite interesting that we've now had 3 past governors presenting in a row. As you know, Dr. now Dr. Altus. So I bring to you Dr. Altus, who's Professor Emeritus for USF. Has been a long-standing faculty member there. Is actually the charter member of the Society of Hypertension. He's been on the Board of Governors, again, and being past governor of the ACP. He also is a Laureate Award recipient, so congratulations to you for that. Has served in capacity of CME for many, many years, and has given over 250 CME presentations. And so he's quite experienced in that regard. Has been peer-reviewed journals such as the Florida Medical Journal, American Journal of Medicine, and Archives of Internal Medicine. And what you'll find also very interesting is he actually started Doctor's Dilemma. So the contest that we are going to see here very shortly is actually his brainchild. So very happy to have him here talking to us a little bit about the history of medicine, and I'm certain some of that will come up as well. So Dr. Altus.
Okay, what I want to talk about today, and it's really an honor to have been asked to give this presentation, is 50 years in the art and practice of internal medicine. Now, I took this quote because I like it. It was the best of times, it was the worst of times. It was the age of wisdom, it was the age of foolishness. Many of you know this comes from the Tale of Two Cities. But we can also say, is this really the last 50 years of medicine that has gone on? 1968, let's go back there, that's 50 years ago. At that time, I was a second-year medical student and was using my required microscope in histology and pathology labs to look at those slides. We didn't have required iPhones or anything like that because they didn't exist back then. My class demographics were sort of interesting. This was up north, this wasn't in the south. We had 107 students. There were 98 Caucasian men and 9 Caucasian women. At the end of the first year, about 3 or 4 of the women had dropped out, so actually in my graduating class, there were only about 4 or 5 women who were left. All the students attended all the classes. There was no things like note services or anything like that. And believe it or not, the men wore ties and jackets to class because you were a professional. The women wore, the 9 women wore dresses and skirts to class. In pharmacology class, which we took as a second-year student, we learned about digitalis. We learned about streptomycin, an important drug in the treatment of tuberculosis, and a new antibiotic that was getting approved the following year that would eradicate all gram-negative infections forever, and that was gentamicin. And we celebrated the 3rd anniversary of Medicare. Now here's a picture out of my yearbook of our class, and you can see all these guys, and believe it or not, in jackets and ties. Now what else were we taught back then? There were no computers. There were no CAT scans, there were no MRIs, no echoes, no ultrasounds, no colonoscopies, no flexible bronchoscopies or sigmoidoscopies, no pulse ox, and I could go on for another 2 minutes telling you what there weren't. But we did learn how to do a complete history of physical from really outstanding clinicians. We were taught how to logically solve puzzles, and we were also taught the importance of compassionate care and the doctor-patient relationship at that time. I like to look back on this as sort of like the golden era of physical diagnosis. Now, again, as a second-year medical student, we were taught physical diagnosis. So I went on the wards, and I remember this lady like it was yesterday. She was 65 years old. She'd been bedridden for 6 months. She hurt all over and could not get out of bed. And nobody had a clue as to what she had. I presented this case to my mentor with the labs. He was a renal fellow at the time. And I said she had slight anemia, she had some increased platelets. He leaped up out of his chair and said, I just read about this last last night in the journals. She has polymyalgia rheumatica, which had just been described about 50 years ago. We all, as a group, were enthusiastic, went running out to the wards, to all the interns and the residents. They started this lady on steroids, and the next day she was walking up and down the hall pain-free. So what's the teaching point that I learned from this one episode? Well, it's critical to read the literature. You don't put a book underneath your bed at night and expect to absorb it through the pillow. Medicine is about constant learning. And that to me is part of the fun of it. Even though I'm sort of an old geezer by now, I still find medicine hugely intellectually satisfying. This is the way I get my stress reduction, by looking at all the new developments that come out. It's also important to read about diseases outside your specialty. If you're going to be a complete physician, you don't have to be an expert on this. But back then I learned that the cardiologists, the endocrinologists, the pulmonologists also knew a fair amount about other things as well. Now, in 1971, I became a resident. Our CCU at that time had 8 beds. The ICU we shared with surgery, it had 14 beds. No one was admitted to these units who had a terminal disease or was over the age of 70. That's sort of scary because I'm over the age of 70. Dialysis was reserved for patients eligible for transplant only. And diabetics, the elderly, and cancer patients, therefore, were excluded from dialysis because at those times, diabetics were not candidates for transplant. We used a PDR. If there are young people out here, that's a physician's desk reference to look up the medications. We used a Washington manual, which was a little book that we all kept in our pockets, which told us how to treat diseases. This was updated every year by the chief resident from WashU in St. Louis and was really our Bible, because we couldn't look up anything on electronic stuff like you do now. We used an index medicus. Again, you have to have a few gray hairs to even know what an index medicus is. These are these big encyclopedic things in the libraries where you would go to find articles and you could research stuff, no medlars. And in fact, we were often found in the library. You know, that's a building or part of a building with a lot of books and stacks and, 2 or 3 floors. We did a lot of socializing in the library as well, but it was like work hard, play hard type of thing. And interestingly, the comment came up about volunteerism earlier. A lot of private internists would make rounds for a month. And those were great for us as students and residents. They were also, I think, very rewarding for the person who was doing that. If they didn't make rounds, they would often work in a clinic. One of our endocrinologists in private practice would go to the diabetes clinic one afternoon a week. And they would certainly enjoy that. And as Dr. Rossi was talking about earlier, when you go out and volunteer stuff, it really gives you that good sort of feeling inside. Now, a few of the medications that were available back then. For hypertension, we had reserpine, hydralazine, thiazides, and aldamet, which was often known as, it was make me dopey, it was alpha-methyl dopa. Probably the only one that you use today are thiazides. Some people still use hydralazine in pregnant women. In fact, hydralazine and aldamet is sort of the drugs often used in pregnant hypertensive patients. The cardiac medicines were DIG, quinidine, procainamide. No statins, no ACE inhibitors, none of that. No beta blockers even that time. Antibiotics, we had a bunch of the penicillins, not all of them, but some of them. Ampicillin, sulfa, tetracycline, streptomycin, kanamycin, colistin, chloramphenicol, cephalin, and gentamicin, but you need an ID referral to get approval for that because that was the super drug. There were also rules, and these are sort of very interesting. These don't exist anymore. All orders were written by the primary house staff team, not by the attendings or the consultants, with a couple of exceptions. So we had a patient admitted for a cardiac cath, the cardiologist would write the cath order because we didn't know anything about that. We didn't want to be bothered by that. But this meant that really the right hand knew what the left hand was doing. GI consultant writing a few things, and then the pulmonary consultant writing a few things, and you as the primary care doctor or the attending, having no idea what's going on. I was totally responsible for my patients, obviously under supervision of the attending. And today, I still look upon a good internist as being like the point guard of a basketball team, the quarterback, the orchestra leader, the person who is organizing everything for good patient care. This led to a whole lot better communication. You spoke with your consultants, and you shared ideas. And I always tried to tell the students and residents that it's important to let your consultant know what you're looking for, know what your concern is. And it's important for, as a consultant, to get back to the attending or the primary care person taking care of the patient, really what you sort of think. And again, advocacy was stressed. Advocacy for our patients was stressed. Now let me give you a few little things that popped up to mind. Let's talk about clinical skills for a minute. Dr. Robert Ike, who was the head of our cardiology department. At that time, full-time faculty were about 25. We have more faculty now in the Division of General Medicine than we had in the whole Department of Medicine back then. But Dr. Ike, tremendous guy, he often said, when all else fails, examine the patient, which is something probably you ought to think about. He would come, I can see it now, he would come walking through, we always used to say, Dr. Ike looked like a giraffe. He was about 6'5" and weighed about 150 pounds. And he'd come bouncing through the CCU at about 6 o'clock at night. And he'd turn to me and say, Phil, are you on tonight? I said, yes. He said, well, watch out for patients in bed 2 and 7, the others are okay. And I said, how does he know that? But he was always right. You know, if somebody crashed, it was the person in 2 or 7. That's it. Everybody else was fine. This again was the time before echocardiograms, and he would predict the severity of mitral stenosis, a disease that luckily we don't see anymore, based on the opening snap of the mitral valve. And when the patient went to cath, he was always right. He would predict aortic stenosis by feeling the carotid pulse and the upstrokes. And he was always right. These are superb physical diagnosticians. Once a month, he was going to the North Country in northern New York State. He'd say to a resident who was doing cardiology, want to come with me? You got to get up at 5 o'clock in the morning. And everyone said, sure, because this was a great learning experience. They'd line up in a big auditorium, big gym, about 50 kids with murmurs. And he'd listen to them and say, you go over there, you go over there, you go, oh, you better go over there. And about 3 or 5 who went over there, he would bring down, get appointments for the captain because they had rheumatic valve disease or rheumatic fever. Again, a disease, luckily, we don't see it anymore. And he also taught us, and I can hear him saying this today, I reserve the right to change my mind at any time. And that's also good in medicine, to be flexible. Not say, damn it, this is the way it is, and I'm not going to change. Because things change and you have to change. Let me tell you about another case. This was a 35-year-old woman who came through our ER, was admitted with left pleuritic chest pain for 24 hours. She took birth control pills, smoked, had a low-grade fever, and a nuclear medicine lung scan, which is highly suggestive of PE, and her PO2 was 74. So she obviously has a pulmonary embolus, right? Dr. Obey, one of our other faculty members, a cardiologist, a terrific guy, he had dog ears. He could hear anything. He took out his stethoscope, listened to her, looked up at me and said, you need to get a pulmonary arteriogram on this lady. I was shocked. I said, why? He said, her second heart sound is soft. Now, if you round with your, Dr. Older, when you round with your residents and you ask them about the second heart sound, they'll look at you like you're speaking a foreign language, probably. The lady got sent for arteriogram, which was the gold standard certainly at that point. It was completely normal. And the diagnosis was changed to pleuritis. She got some treatment, went home, did fine, no problems. One night we admitted 15 patients. There were no caps. We had a man who had an upper GI bleed, which was stable, but interestingly, he also had sinus and bursts. I was the resident at that time. I said to the intern, listen, don't tell Dr. Streeton, who was our attending, an endocrinologist, don't tell him about the the sinus person who got 15 patients to staff. Just tell them about the GI Bill. So we did that. He went to the bedside, asked a few questions, and said, well, I'm going to examine you now, Mr. And then he looked up to us and he said, you didn't tell me you had dextrocardia. This is an endocrinologist staffing a case on GI bleed, but he took a step, he took his hand first, and he went, and he felt now an impulse on the right side instead of the left side, and he said, this guy has dextrocardia. These were the people that I had the pleasure for whom to learn, to try to emulate some of their abilities. There's also a lot of, like I said, communications and working together. There's another lady, right before I left my residency, 58-year-old lady, transferred from another hospital who had unstable angina and severe hypothyroidism, virtually mixed edema. Almost a mixed edema coma. She was sent for a cardiac cath and a possible CABG. And the cardiologist said, well, we can't do that with her mixed edema. We'll kill her by doing that. So we say, let's give her a little bit of thyroid. So we walked in the room with a bottle, let her look on the bottle, and she had angina. That was basically it. So he said, well, let's give her a little bit of propranolol, this new beta blocker that was now out. And with 10 milligrams of propranolol, her heart rate went to 35, and her blood pressure was 90. Sometimes it was a little below. So what can you do? This is sort of a conundrum. You can't get her thyroid because she'll code on it, she'll have an MI. And you can't beta block or anything because she won't be able to survive that either. So, Dr. Ike and Dr. Street talked at length and said, how can we solve this problem? And the endocrinologist, by the way, and I said, you have to know a little bit about stuff outside your field, came up with a novel approach. And that approach was, let's put in a temporary pacemaker on her, a transvenous temporary pacemaker. We'll set the rate to 55 so that we can give her some of the propranolol and her heart rate will hold up because of the pacemaker. And then with a little bit of beta blocker on board, we can titrate up the thyroid. And that worked great. The lady went to cath, the lady went to surgery, and the lady walked home afterwards, having been revascularized. Now, there were some key learning points from my residency, and that is always do a complete history of physical, and please, the patient needs to be undressed. You cannot hear. I've seen 2 patients admitted to the CCU for acute coronary syndromes, pain in the chest with radiation to the left shoulder, and they had zoster. Okay, it's hard to tell zoster when somebody has their shirt on. So you've got to get the patients undressed. Your patient is your responsibility, and you should be captain of the ship. Pathophysiology never changes. Drugs change. Drugs change more often than I change my socks, but pathophysiology doesn't change. Always step back and think. Ask questions to both yourself and others, and don't be afraid to say, I don't know. I've always said, I don't know are my 3 favorite words, because when somebody says, I don't know, I say, they've identified the bullshit line over which they don't cross. Okay, and it's no problem, because a lot of us don't know a lot of things for sure. And again, medicine changes, read a journal and get some good CME. Now, thinking outside the box, you have to do that something. One of my favorite sayings is, if it's intuitively obvious, 50% of the time it's wrong. And we've seen that. For years we thought estrogens were cardioprotective until they did the good randomized controlled trials. Antiarrhythmics decreased sudden death until we did the good randomized controlled trials, and we found that they have pro-arrhythmic effects and they increase death. Beta blockers are bad for heart failure. I would have been thrown out of my residency if I gave somebody a beta blocker. Now they're cornerstones for heart failure. How about this one? When the blood pressure is lowered to 120 over 80, keep in mind the patient is still at much greater risk than those with the same blood pressure who are never hypertensive. That's an interesting thing. And I remember John Lara, the founder of the American Society of Hypertension, used to say an elevated blood pressure is like an elevated temperature. It's It's a sign that something else is going on under the surface. If your temperature is elevated, it's because you have infection, you have inflammation, you've got something. If your blood pressure is elevated, it's because you have endothelial dysfunction. Okay? And lowering the blood pressure per se doesn't get rid of that. So maybe we ought to look at treating the endothelial dysfunction and not just treating a number. And just for fun, if you don't believe this, you can go home and go on your computers, because we all have computers now, and pull up the Framingham risk model. I did this last night just for the fun of it. I put in my age, my numbers, okay? It asks for you whether you're a smoker, you know, your total cholesterol, your HDL. And what I found out is if I put in a blood pressure of 140 over 90 on no medications, I have a lower risk than a blood pressure of 120 over 80 on medications. It's an interesting concept, and that's because there's something going on below the surface. Another question, when does diabetes start? People have asked this, and this is an interesting thing because we all seem to, well, you know, my doctor just told me I had diabetes. Well, guess what? You've had problems for 10 years or so. And there's really good data on that. There's actually, going back to the hypertensive thing, there's data similarly with hypertensives that they have abnormalities before the blood pressure actually shoots up. In the diabetics, you have insulin resistance, in the type 2 diabetics predominantly. And because of that, your pancreas puts out more and more insulin and keeps the blood sugar under control, while other things are going to hell in a handbasket. Your triglycerides are going up, your HDL is going down. And I remember in 1974, at an ACP meeting in San Francisco, where Marvin Siperstein, a famous diabetologist from the University of San Francisco, said at the time that diabetes is diagnosed, when the sugar is high, if you biopsy the quadriceps muscle, you will see thickening of the basement membrane, the hallmark of the vascular change in diabetes, in over 90% of your patients. That's because things have been happening for 10 years before the sugar really goes to hell in a handbasket. Well, let's look at some of the things back then and some of the things now, and we'll start with breast cancer. 1970s, if a woman had breast cancer, she had a modified radical mastectomy. They removed the whole breast, they removed some of the muscles on the chest wall, they dissected out all the lymph nodes in your axilla, leading to lymphedema, and the patients were hospitalized for 1 to 2 weeks. Now, in 2000, this is a real patient of mine, 78 years old at the time. She had a positive mammogram. She had a small lesion. She had a lumpectomy and a sentinel node biopsy with frozen section, all interlocal. The sentinel node, luckily, was negative for her. And the surgeon said, if you want to stay overnight, you can, but if you have good support, you can go home. She said, I'll go home. So instead of having all this major stuff, she has minor stuff. She is now 95 years old with no evidence of disease. In fact, she and I go out to lunch every 3 months because she was one of my favorite patients and we have a good time together. How about cardiology? If you had an acute coronary syndrome back then, you were admitted to the CCU. If an MI was ruled out, you were sent home in a few days, not in a few hours, because it took, especially if you were admitted on Friday afternoon, it took Monday before you knew what the CPKs were. There were no stat troponins or anything like that. Now, if you had an MI, you bought yourself 3 weeks in the hospital. The first week, you were flat in bed in the CCU. They wouldn't even let you read a newspaper, hold it up, because that much stress would come on. The next week, you were on the floor with a bedside mode. And the third week, you were able to walk in the hall. The treatment was oxygen and morphine for pain, lidocaine for arrhythmics, and digitalis if you went into heart failure. Nitrates and beta blockers were contraindicated, and the only blood pressures were treated was if you were over 180 systolic. And heparin was debatable. Most people, if they used it, it was probably to prevent the DVTs you were going to get if you were lying in bed in the CCU for a week. How about now? You have an acute coronary syndrome, you come to the emergency room, they rush you up to the cath lab, they open up your blood vessel, They use nitrates, beta blockers, thrombolytics, dual antiplatelet agents, antihypertensive statins. If you're revascularized and stable, you get a few days in the hospital, no loss of myocardium, you get started on cardiac rehab, aggressive medical therapy to try and prevent the next event. And we now know that it's more than just the vessel getting clogged up with plaque, that inflammation plays an incredibly important role in this. And that's one of my interests. If you want to talk about that later, I'd be happy to. Now let me give you a real life patient, because I learn things from real life patients as well as from reading books and stuff. This is a physician who I took care of. He used to actually work at the NIH until he retired down here. He had a significant stable angina, and he couldn't tolerate beta blockers or nitrates. Now, he went for a cath and had a tight lesion in his diagonal branch, and because he was really bothered by this, he had an angioplasty. This was before stents, and he did okay. A few years later, he was in Seattle at a medical meeting, checking out from his hotel, and he had acute coronary syndrome, crushing pain. They whisked him over. The hospital was right across the street. He had a successful angioplasty of the circumflex artery. 3 years later, I got a call from him on a Sunday morning. He's up in New York and he's had chest pain. Is it okay to fly home? And I said, no, go to the hospital. So he had a successful angioplasty of his right coronary artery. And a few years later than that, he called me up and he said, I'm having chest pain. He said, I've already chewed 2 aspirins. And he said, call 911, get into the hospital. And he had an angioplasty of his LAD. When I retired, he was 90 years old, angina-free, normal ejection fraction, no cardiac symptoms. That's progress. How about hemon in that area? And I get into sort of thin ice on some of these things. Acute lymphoblastic leukemia was almost always fatal back in the 60s and 70s. Now it's probably 90% plus curable, not just treatable. Hodgkin's disease was often fatal. Now most people get cured. A lot of ball players get Hodgkin's disease, get chemotherapy, and next year they're out pitching in the major leagues. Lymphoma was often fatal. Now many of the cases were cured. Metastatic testicular disease was a fatal disease. That was Brian Piccolo. He had that. Now almost all of those can be cured, or at least many of them can be cured. In the heme field, promyelocytic leukemia, acutely fatal. Now it's treated with these old transretinoic acid drugs, and a lot of people do have normal survivals. CML was a fatal disease. Now it's treatable with these tyrosine kinase inhibitors. AML was rapidly fatal. Now some people can get cured, but not all by any means. Some of you may have heard of, the older people in the room may have heard of Ernie Davis. I went to medical school in Syracuse. Ernie Davis followed Jim Brown. He was a football player. He was better than Jim Brown. Ernie Davis was the first African-American player to win the Heisman Trophy. In 1962, he was the #1 draft pick in the NFL, and a couple of months later, was diagnosed as having AML, and 1 year later was dead from that disease. A tragic thing. A great ESPN bit on the Elmira Express. Colon cancer was often diagnosed after symptoms of a hematoma stool or obstruction. It was far advanced. Now with colonoscopy, you find a polyp, you take the polyp out, you don't get colon cancer. Some people with metastatic melanoma, a quickly fatal disease, are responding to immunotherapy, like Jimmy Carter, brain mets and everything. And as I mentioned, mammography is picking up smaller, earlier lesions. By the time you felt the grapefruit in a woman's breast, it was too late. But we're doing a little bit better now. How about infectious diseases? In the 70s and 80s, diagnosing infectious diseases took a long time. I remember sometimes it would take 3 to 4 weeks to get a TB culture back. While there were limited antibiotics, however, one could usually find one that worked. There wasn't a whole lot of resistance down there. 50 years ago, we didn't see C. diff. It may have been there, but we didn't see it. We didn't see Legionella. That came in the 70s. We didn't see Zika. It may have been there, but we didn't see it. But interesting, we saw things like malaria, with all the Vietnam veterans coming back to the States. And our VA hospital at any time had 3 or 4 people hospitalized with malaria. And we saw the sequelae of rheumatic fever disease that I said, luckily we don't see anymore. HIV in the 80s was a fatal disease, and hepatitis C had no treatment. Well, how about now? Well, we sort of a trade-off. We now have a lot of resistant organisms, things to MRSA, VRE, and so forth. We have some of the iatrogenic diseases like C. diff. On the good side, we have PCR, which gives us a quick diagnosis. You know, I hear some cases every once in a while, you know, well, we did a PCR for TB on the spinal fluid. Whoa, like that would take me 6 months to get back. And there's shorter and less intensive treatment times for a lot of diseases. Pneumonias are often treated as outpatients. Pyelonephritis in the 70s was 7 to 10 days in the hospital IV antibiotics. Now it's, you know, some antibiotic du jour and a la carte. And TB, instead of a year's treatment, the courses are much shorter. HIV, as you know, is treatable and often a chronic disease. Magic Johnson. Good pills, take your medicines, you can do okay. Hepatitis C, as we heard the other day, over 90% of the patients can now be cured from that, which was an incurable disease. And we now have immunizations for varicella, zoster, HPV, hepatitis A, hepatitis B, H. flu, pneumococcus, you know, not eliminating that, but certainly reducing the chance of getting these diseases. Looking at the GI field and peptic ulcer disease, in 1968, 90% of the GI bleeders were admitted to the floor. I talked about ICUs. If you were a GI bleeder to get in the ICU, you had to be in shock, period. We had good care on the floors. In fact, we had a little student lab at the end of the floor where you could do hematocrits. And you'd get a little, stick the person's finger, almost like an Accu-Check, and have a little pipette tube and run it in a centrifuge. And student run back and say, it's 35% now. Good, we're going up here. Treatment, as Dr. Nadell remembers, was milk and Maalox, right? Alternating on the hours. On the even hours you took one, the odd hours you took the other. You go into a patient's room, you see that big container, cardboard thing with ice on it, a quart of milk in it, because the patients would take their milk and Maalox for themselves. And recurrences were often and treated often with surgery, pyloroplasty, or megatomy, or partial gastrectomy, and we all know the cause was too much acid. Well, how about in 2018? Most patients who bleed go to the ICU. I don't know if that's good or bad. Treatments are PPIs and H2 blockers. Surgery is rare. I don't know the last time I heard of someone being operated on for peptic ulcer disease. And we now know that this is not a GI disease, but an infectious disease in most cases with H. pylori. Interesting, the person who first talked about H. pylori was thrown out of the GI meetings as being crazy, and then a couple of years ago was given their highest award. You have to change you reserve the right to change your mind at any time, okay? How about stroke? Prior to effective blood pressure control, we saw a lot of patients with stroke. Now, you see elderly patients more than, but we used to see a lot of 50 and 60-year-old people with stroke, and the treatment was bed rest and maybe a little PT afterwards. Mortality was high. Keep in mind the 3 leaders of the Allies during World War II, Roosevelt, Churchill, and Stalin, all died from strokes. Now, we have better antihypertensives, emphasis on blood pressure control, statin use, and the incidence of ischemic stroke has decreased. We have some anticoagulation that's reduced stroke with AFib. We've tried to educate people in the early signs of stroke so that they can get early care, because with early care you can use thrombolytics and maybe even thrombectomy, which has decreased morbidity and mortality. Well, as we know, the world has gone through a bunch of ages: the Bronze Age, the Stone Age, the Renaissance, the Industrial Revolution. Now we're in the Tech Age. So during my career, I've seen computers, chips to power everything: CTs, MRIs, echoes, ultrasounds, telemetry, PET scans, all sorts of things. I've often said, however, a good clinician should not be a slave to high tech, but high tech should work for him or her. Now let me give you a thing. Again, going back to what I was trained to do. I wasn't trained to do CT scans. I was trained to do a history and physical. Here's a case of mine. These are all real cases. A 30-year-old man complains of back pain. I am the third physician he has seen, the last choice, after an orthopod and neurologist. He's already had a CT scan and MRI, both of which were unremarkable. He says he feels like his back is inflamed. It's a strange thing. I've had very few people with back pain telling me that they felt like their back is inflamed. He denied any other symptoms. When I started asking him some more questions about things like activity, he says, well, you know, it's interesting because when he went to his wife's Lama's place, he was the only one who could not bend over and touch his toes. I thought that was sort of interesting. His family history was, no, everything was fine. I said to him, but tell me about your father's back pain. And he said, how did you know my father had back pain? I said, well, I need to send you for an x-ray. He said, I've already had, CTs, MRIs. I said, well, I want to look at your SI. This is a long time ago, actually. And he went and came back and he had sacroiliitis and he had early ankylosing spondylitis. So the take-home point, he said, listen to the patient. They will often help you make the diagnosis. He told me he felt like his back was inflamed, and he was absolutely right. He had AS and his back was inflamed. Now here's an interesting lady, 70-year-old lady, who presented with abdominal pain. And she had she was seen by one of my colleagues. This was like the whole clinic took care of this lady. She was a private patient of Dr. X who was away on vacation, so Dr. Y saw her in the clinic. And he was concerned enough that he did a CT scan and CT of her abdomen and chest, and she had a left renal mass and 3 metastatic lesions in her liver. And she was admitted to Tampa General for further workup. Now, her son-in-law was a departmental chair at the College of Medicine, and her son was a physician, just the type of people you like to deal with, right? And her son says, well, you know, she's got this metastatic disease in her liver, and that's not good, and I don't want my mom to suffer. Maybe you need to call hospice. Dr. Mike Flannery, some of you know him. He's a former ACP council member. He succeeded me as program director. Was on service, and he said, well, let's get a liver biopsy. And he did that. It was non-diagnostic. July 1st comes, so I come on service, and I say to the IR, I want to repeat the biopsy. And I say, well, this time it comes back purulent material. She is treated with antibiotics, resolution of her metastatic lesions, which were really abscesses, underwent a nephrectomy with negative nodes, lived happily ever after to age 90 with no evidence of carcinoma. Actually, unfortunately died of Alzheimer's disease. Now, this is under the title of pathophysiology. Was this great work by Dr. Flannery and me? And the answer is no. A well-trained internist should have worked this out. And why is that? Where does renal cell carcinoma metastasize to? Lung and bone primarily, not liver. And this lady had no involvement of either lung or bone. So I'm not saying it couldn't be metastatic disease, but it should have raised enough red flags so that if you step back and think for a minute, you should say, I'm not satisfied with this. Don't be a slave to technology.
Yeah.
This is a 75-year-old diabetic man. Again, not my patient originally. I followed him afterwards, a patient, Dr. Edelman, remember. He was admitted to Tampa General Hospital, right upper quadrant pain for 24 hours, nausea and vomiting. The residents ordered a lab and an ultrasound, right upper quadrant. The labs with elevated white count, transaminase, and bilirubin. Ultrasound was negative for pathology. So Harold Edelman said, you know, I admitted my patient here, but I'm up at the USF. Can you go? I said, sure, I'll be happy to. I go and ask the guy some questions and examine him. You know, all else fails, examine the patient. He had severe right upper quadrant tenderness and rebound. He was taking the surgery. He had a gangrenous gallbladder, which was about ready to rupture, in spite of the fact that the ultrasound was negative. Okay? Don't be a slave to technology. Now, let me show you this. This picture occurred, was in the Tampa Bay Times about 3 months ago. The first heart transplant was done 50 years ago, 1968. In the U.S., the first U.S. adult human heart transplant done by Norman Shumway in Stanford. 1968, the patient lived for 3 weeks. The immunosuppressants then were prednisone and Imuran. Cyclosporin didn't make it out until the 80s. So why am I talking about this? Why am I showing you this picture? This is Debbie Rindy Hoffman, one of our former students, residents, and fellows. I can give our people a little plug here. She now heads up the heart failure program for the transplant service at Tampa General Hospital. And some of you may recognize this man or may not. I forget who these two people are. This is former Vice President Dick Cheney. He had a heart transplant in 2012, 6 years ago. And as you can see, he looks pretty good here. In fact, he looks a whole lot better than he looked when he was Vice President. He's got a better heart. Transplantation has just incredibly changed things. This is some numbers from Tampa General from 2016. And that year they did 42 hearts, 40 lungs, 237 adult kidneys, 15 pediatric kidneys. I was thinking about that. Now, you know, hospitals work 7 days a week, 24 hours a day. If you play a game and say, let's exclude weekends and holidays, that means they transplanted a kidney every day, if you look at that. 65 liver transplants, 19 combined kidney and pancreas for the people with diabetes, type of thing. Since 1975, they did over 5,000 kidney transplants. They started doing hearts in 85, and since that time, they've done over 1,000 hearts. Well, let's ask a question about what makes a good physician here. Because that's what we're trying to be, a good physician, right? Is the goal, and this slide, and I apologize, is all philosophy. And it's my philosophy, and you can agree with it or you can disagree with it, and I'll respect anyone's opinion who doesn't like any of this stuff. But anyway, is the goal to prevent death? No, we never prevent death. The goal, hopefully, is to delay death. So then is the goal to prolong life? Well, my philosophy is not necessarily. Doesn't mean I'm going to go out and kill everybody. But keep in mind that life is geometric. It has a length, but it also has a width. And I think we were stressed out in our schooling and training that quality and quantity of life also have to be. And our real goal should be to provide a long quality lifetime for our patients. Now here's the question of the day. Anyone who gets this right, I'll buy you a cup of coffee out there. What do a physician, shortstop, and plumber have in common? Now I asked this to somebody, and they said, well, that's easy. They all wear gloves. But that's not the answer. The answer is some are outstanding, some are not good at all, and most are really in between, as seen in a bell-shaped curve. And we should really all strive to move to the right-hand side of the bell-shaped curve, the better side. And this is where CQI comes into effect, continuous quality improvement, and that sort of thing. Now, I thank Dr. Oler, who made this slide for me because I'm too old to make these funny things. I tried to make these bell-shaped curves, and I couldn't do it. But she's a star. This is 1968 physicians, and here's our bell-shaped curve. Some are really good, some are not so good, and most of them are sort of in the middle. Now, as you can see, this is a sort of narrow bell-shaped curve, and I made it that way on purpose because back then, the difference between real good and real bad didn't matter that much because there weren't a whole lot of things you could do for people. Okay? If someone came in with an MI, you virtually babysat. I hate to say that, but that's what it is. And this whole idea actually came to my mind from an experience I had in the 50s when my uncle had a heart attack, and my father said, you want to go see, I'm going to go see Uncle Lord, you want to go with me? I said, sure. And he was in a 4-bed ward in an oxygen tent. That was the treatment back then. So it didn't matter whether you were real good or real bad. It was, survival of the fittest, I guess. This is 2018. Now the curves are wider. So it really is important to try and get to this right-hand side for you and for your patients, because the difference between what you know now that you didn't know then, and what you can do now that you couldn't do then, is a whole lot greater. You know, I was thinking about this, and I was thinking of going back to my residency, and I always thought I was sort of like an average resident. I was, you know, like in this area. And I always think of things, and I told this to the residents, like, what makes a good shortstop? And the answer, in my opinion, is not the highlight films on ESPN. It's not screwing up the easy ground ball that's hit to you. Not to make the errors, okay? And for physicians, a key thing, again, trying to move to the right. How do you move to the right? And I think the number one thing is attention to detail. Now, you gotta do a lot of things. You know, you gotta keep on increasing your knowledge, it's keeping up in it, but attention to details, because more screw-ups that I've seen have been because somebody dropped the ball. They missed out on things. Don't drop the ball. Let me tell you about this man. I've dropped the ball. When I've dropped the ball, it's been not usually because I didn't know, it's because of lack of attention to detail. So everyone can do it, you have to just try and force yourself to not do it. This was a 70-year-old man with hypertension who came for an initial visit to me. It's an interesting story. He lived up in Saginaw, Michigan. And he used to go to the VA in Saginaw, and he just moved to Tampa, and he said, I hear there's a long wait at the VA, Dr. Lozano, and now that I have Medicare and everything, so I thought maybe I'd try you out and avoid the wait. So I said, that's fine. Then I took a history of him. He'd been treated in Michigan, and his blood pressure was okay. That was what he told me. His history was negative. His blood pressure was 130/84, and a pulsatile abdominal mass. That's not okay. So I sent him for a stat ultrasound, and he had a large abdominal aortic aneurysm. He was admitted to Tampa General, had a stent graft placed the next day. So on a social visit, I had this, quote, bad habit, is he was my patient, even though I only saw him once, but I figured I'd go see him. No one asked me to see him, but I made a social visit. And he said, why did they find us in Michigan? And I asked, did they examine your abdomen? I was in one of those moods, you know. I guess maybe he's stressed out. I said, did they examine your abdomen? He said, no. They just asked me questions, took my blood pressure, refilled my meds. Okay? Error on the shortstop. I used to play a game in my clinic with the residents. I would see one of my hypertensive patients. You know, I'd ask them the usual questions, chest pain, shortness of breath, funny feeling in your arms or leg, whatever. And then, you know, I'd have them get undressed and hop up on the table. And there they were, undressed, because you have to get undressed, from the waist on up. And I'd say to the resident, okay, time this as I examine it. And I'd go through my thing, and, you know, I got into a rut. I knew what I was doing to him. I feel his neck for lymph nodes because it's not just hypertension. You know, he could get lymphoma or something like that. I'd listen to bruits over his carotids. I'd listen to, you know, I percuss out his lungs. I auscultate his lungs. Okay, I'd listen to his heart sitting up. Can't hear AI lying down. Then I'd say, lie down. I'd listen to his heart again. Feel his belly. Listen to his belly, you know, feel for organomegaly or whatever, check his legs for edema, feel his pedal pulses, and then finish up taking his blood pressure. And I turn to the resident and say, how long did that take me? And he'd say, a minute and a half. And I'd say, don't ever tell me you don't have time to examine the patient. Because if you get this down pat, you can do this in a minute and a half. This man, and this is not an exception, unfortunately, this happens a lot of times. They just said, you doing okay? I'm doing okay. Check your blood pressure. Your blood pressure's okay. Here's your prescription. Come back in 6 months. This wasn't a great pickup, you know? Anybody could have picked this up. Now, how do you get to the right side of the curve? Again, sort of thinking a little bit out of the box and thinking about things. Here's another, one of my favorite patients. I hardly ever saw this lady, but she was, I like her because when I retired, she gave me a plant. A 35-year-old woman who was sent by her GYN doc, who was a very good physician, by the way, for treatment of her high cholesterol. had been 240, and she'd been on this low-fat diet, and still 240. And her history was negative except for her father got a cabbage at age 58. Physical exam, she's 5'2", weighed 125 pounds, her blood pressure was 124/80. The rest of the exam was negative. And these are her labs. Her cholesterol is 240, her HDL is 35, triglycerides 350, her glucose was 98. So this was in my clinic, and I saw patients with residents. The resident had told me all this story, and then I would go in and ask more questions and repeat things and stuff. So what do you do on this lady? Well, I walked into the room. The first thing that impressed me, and the first thing you do is you look at the patient, right? You don't just sit at your computer with you look at the patient. The first thing I noticed in this patient is that she sort of had a strange shape, like this. I mean, she's not overweight, but she's 35 and she looked like this. So what did I do? Well, I got more history, and I said, how about your father? Did he have diabetes? And she said, yeah, how'd you know that? I said, well, I asked the other guy about his father's back pain. I would ask you about diabetes. And then I said to the resident, go out and get a tape measure. And she said, what are you going to do? I said, I'm going to measure your waist and your hips. And it was 0.95, which is significantly elevated for a woman. So, what is this woman's problem? And her problem is not her high cholesterol. Her problem is that she's inherited her father's genes. She has this insulin resistance type of stuff going on. Her glucose is okay now because she's pouring out a lot of insulin, but look at her triglycerides and her HDL. She's a premenopausal woman. So, we had a long talk. She said, I hope you're not going to put me on one of those pills and everything. I said, no, I'm not going to put you on a pill. And what I said to her was what I said to a lot of patients back then. I said, listen, what I want you to do is I want you to get into a strict exercise program, 150 minutes a week. We heard about that the other day, the diabetes prevention program. Terrific data on this. Brisk walking. And on your way home, I want you to stop off at Barnes & Noble, get a cup of coffee, put your feet up, drink your coffee, and get a copy of the book off the shelf called Sugar Busters, which was a book started by the people at the Oxford Clinic, which the people in Miami, the South Beach diet sort of plagiarized a lot of it. But it's basically a low glycemic index carb diet type of thing. And go on now, because you've been on the wrong diet. When you're on a low-fat diet, you replace it with carbs. Like this, right? So, she comes back 6 months later, a year later, and here are her numbers. Her weight has gone down. Now, she wasn't overweight to start with. She weighed 125, but she's lost 6 pounds. Her waist to hip ratio has gone from 0.95 to 0.75. Now she looks like a Barbie doll. Am I going to get in trouble for saying that? I have help from Dr. Uller and Dr. Humphrey because I get my hands slapped. Her total cholesterol is 200. It was 240. Her HDL has gone from 35 to 47. Still below that 50 number that we like in women. This is better than any drug would do. Her triglycerides have gone from 350 to 180. That's better than any drug will do. Her glucose has dropped a little bit. And I followed this lady for about 4 or 5 years. She was absolutely, totally adherent with her diet and her walking and everything. And her numbers basically stayed the same. Does this mean she's not going to get into trouble? Well, she probably will at some time, but it's the concept of delaying the thing. More quality of life for more years. And that's one of our goals. We're not going to, in this day and age, change her genes by any means. But I think, I left the office seeing these numbers, and that to me made me feel good. And she felt good. She felt good enough to give me a plan. What more could I ask for? Well, let's look back at the 70s and our concept of the best of times and worst of times. In the 70s, there was incredible professionalism. I'm not saying there's not professionalism today, because there is, but this was so thick. Physicians were regarded highly, probably second only to the clergy at that time. Our time was almost all devoted to patient care. There was virtually no paperwork or meaningless chores. I mean, we had patients at our VA who'd been there for 3 months, who were stable and everything. I remember as I would write a note, no change, doing well. You know, I didn't have the Medicare police say, wait, you didn't have 5 of these and 4 of these and something like that. The relationships were terrific. As captain of the ship, the primary care physician had a strong doctor-patient relationship with mutual trust. And I received a lot of Christmas gifts from these patients, homemade things and stuff. There was an incredible strong camaraderie among physicians. We all worked together, we had to work together. We helped each other out. And this volunteerism and a feeling of satisfaction was out there. People were doing a lot and feeling good about it. On the other side of the coin, there were limited things that one could do for our patients, but we didn't know that. We thought we were doing a lot, we weren't doing squat most of the time. Many physicians worked long hours and they had little time for family, but you know, when that happens, when you do get home, you really have quality time with your family, because you know it is limited. Let's look at our medical students. I told you about my class, 98 white men and 9 white women. This is data I just got from Dr. Wagner at USF. It's not complete yet. In the incoming class, there are 176 students. Now, instead of 98 men and 7 women, as you know, just by looking around, the gender is about 50-50. This I have to explain a little bit. There are about, and he doesn't have the exact numbers yet, 15% underrepresented minorities in the class. Now, the definition of underrepresented minorities, they take people in the country and physicians as a percentage. Okay? So the underrepresented minorities, by definition, are self-identified as African Americans, Hispanics/Latinos, Native Americans, Pacific Islanders, and mainland Puerto Ricans. Now, what's missing from this list, as you can imagine, are Japanese, Chinese, Vietnamese, Indians, Pakistanis, and Middle Easterners, which there are a fair number in all of our classes. So this number of underrepresented minorities, I'm not saying they're underrepresented, but they're not the Caucasian white men and women like grew up in the 70s in most of the medical schools. And this gives us a nice diversity in our students. Now let's look at 2018. Is it the best of times? We have made great progress, and I've shown you some of this stuff, the things with cardiac care, cancer care and everything. It's incredible what's going on. But there's also some other things that, unfortunately, many bacteria we know are resistant to antibiotics. Obesity and diabetes are greatly increasing. And we've got to work with our pediatrician friends and other people to try and do something about this. Cancer rates in certain areas are rising. Lymphoma, which used to be a pretty rare disease back in the 70s, is now a whole lot more common than what it used to be. Does this have to do with air pollution or whatever? It's unclear. Does this have to do, certainly people are living longer, but even age-adjusted rates are going up. Over 50,000 people died last year from opioids. That's a number that is totally unacceptable. While we spend more dollars than any other country, the U.S. ranks 40th in years of health. 40 years of health, and that's like quality years, not life expectancy, but quality of years. So, you know, it eliminates living ages 80 through 85 with Alzheimer's in a nursing home. The U.S. was one of 5 countries where life expectancy actually fell in 2016. The other 4 countries are Somalia, Afghanistan, Georgia, and my famous rock group, St. Vincent and the Grenadines. That's probably related, or partially related, to the 50,000 opioid deaths that are occurring. But this is sort of a disgrace when you put us in with Afghanistan, Somalia, and Georgia for medical care. And as we all know, the price of medications have risen exponentially, and a a lot of money is spent on administration. We could talk about that till the cows have come home, about money for R&D and all that stuff. But old drugs, things like EpiPens, shouldn't be $500. Colchicine, a drug that's older than everybody in this room, shouldn't be enormously expensive. In the 70s, it was a penny a pill. Now I think it's $1 a pill. There's no R&D into that. There's other things. We take care of patients who have other problems. Let's look at some of the improvements outside of internal medicine. 1968, cataract surgery, 7 days in the hospital. I remember my mother having that. Sandbagged for 3 days. That was what happened. Today, it's a 2-hour outpatient. It doesn't take that long. It takes 2 hours from when you leave home to when you get back home. Hernia repair, 7 to 10 days hospitalization. I had one of those. I went to Tampa General at 4 in the afternoon and I was home at 9:30 at night. Type of thing. And 3 days later was on a cruise ship. With the only limitation, I couldn't lift anything over 10 pounds, so I had my wife carry all my luggage. Total hip replacement used to be 3 weeks. Now, speaking to Dr. Gusky at FOI, it can be done sometimes as an outpatient or a couple of days. Elective AAA repair, 2 to 3 weeks hospitalization. First week in the ICU, often. Now with the stent grafts, if you're doing well, you go home in 24 hours. So it's incredible, and these are common diseases that we see, or common problems that we see in our patients as the patients are getting older. There's a bunch of future questions, and one of the only regrets I have is I won't be here 30 years from now to see what's going on in medicine. I doubt it. If I am here, I won't know it. But some of these diseases, autoimmune and other diseases, what causes inflammatory bowel disease? What causes rheumatoid arthritis? What causes lupus? What about ALS, multiple sclerosis, Alzheimer's? It'd be nice to know what causes, because that's the key to what to do about it. In cancer, and this is exploding every day, and I get stuff thanks to Medscape and so. What's the role of immunotherapy? What's the role of molecular and genetic therapy? I read an article, a paper, actually it was an abstract, about 5 or 6 months ago. They had identified an enzyme in the colon which promotes the development of polyps and the progression from polyps to cancer and the growth of cancer cells of the colon. And the question is, and they're starting to do some work on mice with this sort of thing, can you develop an inhibitor to this enzyme? So like an ACE inhibitor type of idea. And maybe that will be a treatment, and you won't have to worry about developing polyps. People at risk or whatever, people who had a polyp removed, been given this drug, block that enzyme, prevent other stuff. A new thing that came out this week about some protein that has to do with development of cancer, and people are starting to look at it. This is where the silver bullets really are in the molecular thing. And 30 years from now, we're not going to be using, all these toxic drugs that we're using now. I would think and I would hope that there's going to be either monoclonal antibodies or something done at the molecular level, the genetic level, or enzymatic level, doing something with the proteins that I don't know anything about, frankly. But that's the way that, cancer is going to occur, but it's going to be treated and hopefully turned into a chronic disease, just like HIV was turned into a chronic disease. In cardiovascular disease, can we identify these people early on who are going to develop hypertension? And we know that there's endothelial dysfunction going on. If you take people into a cath lab and infuse arginine instead of vasodilating, they vasoconstrict these people. So we know that stuff's going on, but is there a way to identify this and a way to make those vessels happy instead of angry type of thing? How can we predict who has the vulnerable plaques? We all know that there's chronic stable angina. Those tend to be hard plaques, and people get pain, it goes away. So it's the ruptured plaque which may not be a big plaque, maybe a 30 or 40% lesion, but ruptures cause an acute thrombosis and an MI. Can we identify those patients better? And really the question of who should be revascularized. So all the debate now about does stenting do any good or not? Does stress testing do any good or not? If you're going to stress test them and pick up the people with chronic stable angina who are not going to develop MIs and miss the people who have 30% vulnerable plaques, that's not going to do us any good. So a lot of these things are coming into question now, and we need good basic science to sort of work this out. What about diabetes? What can be done to stop the obesity epidemic? That clearly plays a role in the rise of diabetes. The question has bothered me forever. Why do some diabetics with an A1C of 7.5 have lots of complications and others don't? And my simplistic answer is, this is just like the temperature and the blood pressure. The elevated blood sugar is a marker for what's going on under the surface. And we really have to get more into that and try and figure that out as to how we can decrease these complications of some of these patients. What causes type 1 diabetes? We know this is sort of like autoimmune thing. This is virus. If it was virus, could we develop a vaccine for it? A lot of these things you think about to improve our patients. And infectious diseases, development of vaccines versus viral, protozoal, and bacterial agents. You know, the whole thing with dengue fever, and dengue as being, you know, part of the component of dengue, and Zika, and that other thing that I can't pronounce, chickachamunga or whatever. And, you know, can we develop a vaccine against some of that stuff and how to treat it? And specific molecular targets versus bacteria. Instead of using antibiotics to kill the bacteria, I once heard at an ACP meeting a lecture about trying to alter the E. coli so that it doesn't stick to the bladder wall. Because if it doesn't stick, you don't get infection of the bladder. Instead of blasting with antibiotics, you try and alter something to do that. Whoops. So in conclusion, technology has fueled tremendous advances in medicine. And we are all privileged to have the ability to do good for our patients with a lot of this stuff. We need good design medical research. And to me, that's randomized clinical trials. I know I may walk to the beat of a different drummer. I've been accused of being a maverick on certain things, but I'm not, frankly, a big fan of meta-analysis. We've seen meta-analysis that have led us astray. I remember Franz Messerly, who's done a lot of work on hypertension, saying meta-analysis is to analysis, is metaphysics, is to physics. So observational studies, that led us down the wrong route with estrogens. There were a ton of observational studies showing estrogens was good. When I became a master, I was sitting next to Elizabeth Barrett Connor, who did most of his work in San Diego. And maybe this was not the right thing to say to her, but I asked her, what do you think about all these your observational studies? I didn't mean it insulting her, because that was right when her study had come out and said estrogens were bad. And she said, well, you know, that's why you need to do the studies. An interesting thing about these observational studies in the women with estrogens is they later found out that the women who took estrogens were more apt to be adherent in taking their other medications, which is something you never measure along the way. But that probably explained why they did that. Randomized clinical trials, to me that's the gold standard. A good history and physical exam combined with the knowledge of pathophysiology, logical thinking, and attention to detail are needed to reap the benefits of our technology. And with all the great science, keep in mind that medicine is still an art and depends on compassion, a good doctor-patient relationship to maximize benefits. Thank you for inviting me to